welcome to the pain panel. We hope this won't be too difficult and painful for you. we in the pain profession tend to have a lot of great pain jokes. Anyway, I'm Mary Burr, and I currently am a nurse practitioner at the Kennedy Greater Institute. My practice is I am a part of a multidiscipline pain, chronic pain team, and we have a tertiary facility for children that suffer from chronic pain disorders. We do outpatient clinic where we do an evaluation. We have an inpatient setting where we can actually get them into the inpatient area and really focus on their pain disorder and provide good services for them. And we also have sort of an intensive outpatient. So can everyone hear me okay? I feel like I'm not projecting, so if you can't hear me, please, may I talk louder? So I would like to introduce our lovely pain panel. I'll start with Elaine Carroll. Elaine, raise your hand. Hi. Elaine is an experienced professional with over 30 years in nursing and healthcare, including hospital-based public health, hospice, and healthcare administration and utilization. In 2008-2009, Elaine began her journey in developing tools to aid in the communication and treatment of children who have experienced emotional trauma. This required extensive research and discussion with providers, nurses, and social workers in what they needed to do in caring for children that were emotionally traumatized. In 2010, Mending Me, LLC became a reality. She published 2 books, Freddie Keeps Ellie Safe in 2014, and The 3 Sisters, A Quest for Mending in 2016. She's a professional presenter on wellness and for children who experience emotional trauma, keeping children safe, holistic health, self-care, and preventing compassion fatigue. Our next panelist is Helen Turner. And I know you guys saw her this morning, or earlier this morning. Helen is an associate director and director for clinical operations in the Pediatric Pain Management Center at Doerr-Becker's Children's Hospital in Oregon. Dr. Turner is a clinical nurse specialist. Her clinical responsibilities include providing pain management for hospitalized and outpatient children. She's a national and international consultant on evidence-based pain management. Dr. Turner is co-editor of the core curriculum for pain management nursing, lectures extensively on pain management, and is a fellow in the American Academy of Nursing and a past president of the American Society for Pain Management Nursing. Deborah Ayres is the third panelist. Deborah's daughter was diagnosed with a rare metabolic bone disorder, hypophosphatasia, when she was a toddler. After 10 years of vigilantly advocating for her daughter's health and wellness, she helped overcome intensive physiologic, emotional, and physical challenges while beginning a painful injection treatment in 2016. Deb and Avi co-founded the Avalon Foundation several months later. Their mission being to help the other pediatric HPP families successfully begin treatment without all of the obstacles. Professionally, Deb is a wellness practitioner for over 25 years. She's an advocate and a healer, and her mission is not only to help individuals, but to also provide opportunities to raise awareness and build bridges of understanding and compassion towards the rare disease community and humanity as a whole. So, with that, we will start this format, and I want to just tell you all, it's the first time I've moderated a panel, so I'm actually looking forward to it. So we have formulated some questions, and we're going to go ahead and I'm going to throw them out to the team, the panel, and let them go at it. And I would really like for the audience to participate anytime. Don't wait to the end. If you have a question or you have a comment or an interjection, please feel free to just stand up, come to the middle of the aisle, just where you are, or where you're seated, and shout out. Okay? All right, ladies, we're going to start with what do you feel is the best response for a child who asks, is this going to hurt?
I'll go for it. Is this on? No, it is.
We've never heard that question before, right?
So I'm going to ask it again. What do you say to a kid when they say, is this going to hurt? When you're getting ready to do some sort of injection or lab draw. Yeah, we tell them the truth because we're all nurses, right? Wrong answer. We don't lie to them, but I think what a very wise child life specialist said to me one time is she said, you don't know if it's gonna hurt for that particular individual. And so if I go around the room and ask y'all, how much does when you get your blood drawn for any lab you have, how much does it hurt? And some are gonna say, God, I hate it. I put it off as long as I can. It's just, and others are like, no big deal, go do it. It's because we're all wired differently. Our kids are all wired differently. So a better, and I think a more useful response is to say, I don't know how it's gonna feel for you. Tell me when we're done. Because you've done a couple of things. You've not set that child up to expect something painful that may not be painful for them, but then you've also given them something to think about. You've done some passive distraction, and that is huge in our kids. They are still able to be distracted. As they get older, it needs to be a little more sophisticated, but it's still a brain that's happy doing something or is processing something that's potentially a lesson is actually a brain that doesn't process some of our primal instincts, like what's this pain and how do I need to respond to it. So that's what when kids ask me that, I used to always say, oh yeah, it's gonna hurt a little bit. I don't know how many of you have ever been stung by a bee. Wasps don't count because wasps bite, bees sting. And I've had a few because I raise bees. But if somebody said, oh, it's gonna feel like a bee sting, I'm gonna be like, no way. This doesn't feel good. So you can't know what it's gonna be like, and to try to put it in some subjective place doesn't work. So that's my approach.
I couldn't agree more. We coach our parents to take the subjective part out of it and to not give the kiddos anything to necessarily expect, but to be open to whatever it's going to be. And if it is painful, you're going to be able to handle it. I'm right here with you. Further, we encourage our parents to make sure that they know that if the child does feel that it's painful, that it's okay for them to cry, it's okay for them to complain, it's okay for that. That's still compliance. They're still receiving the treatment, as opposed to running away, hiding, etc. So to be very honest about their feelings and let those kids process out what they're feeling is important. They can say it while they're doing it, and a lot of that comes down to also that allows them to have some control over them deciding what that experience is going to be for them. So that's
Control is huge.
Yeah.
I think the third component, and probably all of you know this, but it's also the parent that's with the child. If the parent is already set in their mind that it's going to hurt, and we do have parents that are very hyperactive, and so it's important that you really, I look at it, you've got to calm the parent down first. And the second thing is, since a parent has told them it's going to hurt, then that's where you have to really do work at saying it may not hurt for you. But and the other thing is that I always ask for people to do is please preach to the parent that just because I'm doing it, parents use it as punishment, some of them do. If you're not good, I'm going to take you to the doctor. He's going to give you a shot. I mean, how many of us have heard that 1,000 times? And that's one of the things that I preach all the time.
When you
Please
hear
don't
that,
say that.
When you
Please
hear
don't.
that, what do you say to the parent?
What do I say? I ask them to please not say that. I really say, please
You
don't
confront
say
them,
that
yeah.
anymore. And I say, it's important that children trust us, because when they come in, I'm thinking of when I did immunization clinics, and we would have a parent that they'd never taken their child for immunizations, and I've now got to give them 6 injections at one time. I mean, would you not think they're already in high because mom and dad has already said, you're going to have these and it's going to hurt, and they may have been fighting along the way because the child's ill, maybe 2 o'clock in the afternoon. They've not gotten to rest, they've not gotten to play, they've been with mom, and they've got to sit in a line because this is a public health area. I've got 500 children that I'm immunizing. So that it's important that indeed, that when you're talking to the parent, and I say, please don't do that. They need to trust the doctor and they need to trust the nurse. And this medication is to help them. And we're wanting them to be able to come back to have the immunizations in a timely manner. And I take the opportunity to do a little education with the parent at the time, but I do. And my friends, they'll jokingly say that sometimes, and I'll go, please, that's not a joke, ever.
Do kids really remember shots?
Yes, they do.
They do. And do you ever have parents that say, oh, they won't remember this?
Oh, yeah. Yes, they do. Yes,
So
they
you would say to the parent at that point, yes, they do remember. Is there evidence to support it? That kids,
That kids
remember
remember?
shots?
I don't have a study off the tip of my hand, but I can tell you, every time the child, when they start crying before they ever enter the room,
Mhm.
you know that they remember.
They're bringing something with
They're
them.
bringing something with them, yes.
I'd like to speak to it as a parent. I have the practitioner side of me, but as a parent, this idea of what the child expects was our complete downward spiral. So my daughter's starting a treatment. We really don't know what to expect. It was a brand new treatment just approved by the FDA. A nurse arrives at our house, shows us how to do it. And my daughter was feeling very confident. She was 10 years old. I'm gonna give myself my injection. Okay, and the interpretation she had, the nurse said, well, it's an insulin needle, so I'm expecting it to be somewhat like an insulin shot. And that's what and so we kind of rode that with her. Okay, it's not gonna be that big of a deal. We know you have to do this the rest of your life. She gave herself that first injection. She needed 2 the first time. My husband had to give her the second one, and that was her downward spiral. So it ended up, she described it as hot lava under her skin. And it was extremely painful and extremely excruciating. She screamed and cried through it. And by the 4th injection, 1 week later, she was absolutely 4-hour standoff with us, refusing to ever do this again. And the reason why was because you all lied to me. You lied to me. I can't trust you. I don't trust my doctors. I don't trust my parents. I don't trust anything any of you are saying to me about this treatment. I know how to live with my hypophosphatasia, but I don't know how to do this now. And she's an extremely mature. She's not a babyish kind of child or weak about things. And so then I was coming up against her strong-mindedness, that she has now decided that she will not be compliant. And that all came from what she interpreted that first shot to be. And that was really tough for us. It led us into creating this organization that helps other kids get through this. But nonetheless, that was very trying for our family.
So it's important to deal with these issues before you go and do the procedure. So dealing with the families and the child's anxiety are all upfront kinds of techniques. That's the best way to handle it. Do you all agree with that?
Yes.
Okay.
And I would agree. There's no way to state that. It used to be that when I was a baby nurse many years ago, our knowledge at that time was that infants didn't feel pain. And that was based on our understanding that pain only transmitted along myelinated fibers, which infants are not fully myelinated. So, deduct from that they don't feel pain. Well, anybody who took care of an infant in pain knew that something wasn't right there, that they distinctly have pain. But then it was like, they don't remember the pain, so it's not a big deal. But I would say and nobody has really studied that, because you can't talk to an infant, so how do you know what they remember? But I can tell you that at 12 months of age, pulling into the pediatrician's parking lot with Zach in his car seat, he would start crying before we ever got anywhere. He recognized that parking lot and knew that something bad was going to happen inside, because the only time he ever went to the doctor was for either really bad ear infections or immunizations. So I think there is a memory piece there. It's just, how do you measure that? And it is really important to, I think, set things up not only from the child's perspective and the parent's perspective when you're dealing with acute pain situations like injections and that, but this plays into a child's life for the rest of their life. And if you don't do a good job managing acute pain, then you end up in our clinics as kids with chronic pain, and there's a lot of data showing that kids with chronic pain become adults with chronic pain. And we set them up from that very, very first interaction. And so that's a critical time if you're gonna do anything perceived as painful. And you know, we'll talk about pulling tape off as kind of a developmental thing. And for some kids it is a developmental thing and an appropriate thing, but for some kids it actually pulls up skin. If I'm working in a neonatal ICU, those babies lose skin every time we take tape off of them. That's incredibly painful.
What role does the child's temperament play in their response to pain?
And part two to that is, what role does the parent's temperament play into
direct
that?
correlation.
Yeah, there's absolutely a direct correlation. Maybe.
And there are studies.
Yeah.
There are studies specific to that,
Yeah.
on resiliency. And if indeed the parent is resilient, then the child will be as well.
Mm-hmm.
It's amazing how you'll have some children that they will have gone some horrific times and they're just happy, and I mean, they are happy. And you have other children that did not go through half that, but their parent is just, pull them off the walls most of the time over anything that happens. I don't know if you ever had the parent in the emergency room and their child is ill and they've totally lost control, and you're trying to do something to help the child, and yet you've got to take care of the mother who is totally, and it's not just the mother, it's generally, you have grandmother there and the aunts and the uncles and cousins, and they're all, it's just a fervor of anxiety. And so of course this child is just as hyper as all of the people around that are acting that way.
So we find that in our program that have home treatments, that it's important to address everybody that's in the household. So we make sure that we profile not only the patient and the parents, but any siblings or any other people that are living in the household. And especially if the siblings are younger, we make sure that there are incentive programs put in place for them as well, because it's important to make sure that when we're starting a home regimen for some of these rare diseases with injections that the parents are doing or the kids are learning to do for themselves, the younger children really need a routine to follow. How are you being a team player? What's expected of you when this is going to happen? And so we make sure that everybody's on board and has an expectation, a responsibility, and for the younger ones, a reward that comes with that, so that routine gets put in place and is supportive psychologically, emotionally for everybody in the household, and that's the best care for the patient.
And I think, question? Yeah.
Yeah, I was just wondering, I was thinking about your response to children when they ask if something's going to be painful, and you say, I don't know if it's going to be painful for you individually. And I like that response, but I'm wondering, do you think there's any benefit to saying it might hurt? Some children have told me it hurts, some children have told me it doesn't hurt, so that they're aware that there's a possibility and there's a spectrum, instead of maybe the younger ones, they might interpret that as being less concrete and more abstract, and who knows what will happen, or the ones that appear very anxious.
I think that's a really good one, a good question, and a good and acceptable approach as well. But even still, just acknowledging that it might hurt, you've almost put a little bit of doubt. There's a chink in the armor there compared to just letting them have a blank slate. And so I probably wouldn't say that, just because it's been so ingrained in me to just say, I don't know, you tell me, because it's your experience. But with a little one, I don't know, let's see. You can do it in ways, you don't have to get real abstract with it, and they can do that. And I think, from the aspect of the parental involvement, I know prior to doing pain management, I was the CNS for our pediatric cystic fibrosis population, and I had one family that we knew the 5-year-old had liver involvement, but we couldn't get blood drawn because mom wouldn't, they'd never stay, they'd leave, they wouldn't come in, that kind of stuff. And I finally figured out that this was mom's anxiety that was driving all of this. So we brought him in, did the whole child life thing, all of this, and the first couple of times, you know, mom was there, dad actually came, sat down with the child. She did great, but mom was a quivering pile out in the hallway. And I left her in the hallway and I said, I think you're gonna be more anxious about this and that's not gonna be helpful for your daughter. I think it'd be better for you to stay out here. And over time, she was able to, sometimes she could be in the room and sometimes she couldn't. But I always knew when we were up for a lab draw, because the week prior to that, the phone calls would start coming in. And so it was recognizing mom's anxiety. And I think for some families, they can learn how to be in the room, but I think for some, it's also okay to give them permission to not be there. If they're able to just recognize this is too much for me. Yeah.
I have a
Sorry.
question pertaining to that with the patients that you were stating, you know, I'm not sure you tell me that, you know, for a lab draw, we, you know, stick and then we miss. And then there's a second, or, you know, or up to the policy of you can up to 3 sticks. How do you suggest to give back the loss of control that patient, that I found in my experience, that they lose that control, they lose that self-control? How would you, you know, if you stick them and I don't know, you tell me and you say, they come to you, this is so painful, don't do it again, please don't do it again, you know.
That's pretty typical, but I think you have to also manage them in, yeah, we need to do this again, so help, let's get it done. Here's the, you know, and don't let them think about it too long is the other piece, because then their anxiety goes up. But the other side of that is, what positioning are you using for blood draws? Because if you're taking a child and holding them down, you've already taken away all of their control. And no matter what you do, even with toddlers, they are not going to tolerate it, because you've taken away a primary developmental milestone of being able to be upright. So looking at positioning for comfort, I've got and I hadn't even thought about it, but I've got a great photograph of an 18-month-old getting a hand IV placed. He's sitting up, he's smiling, he could care less, because he's got bubbles and he's got a pop-up book and he's sitting upright. The nurse is behind him, just there, and she can contain him if she needs to, but she's not gonna lay him down. He had, you know, one of the creams on the back of his hand, and that's all he had, but very successful. And that was a study that was done, repeated successes like that. So, but you also have to, you know, we didn't get it, we've got to do this again. Just be very, I think, consistent, straightforward, and don't let it drag out.
Is there a way to repair the loss of control for a patient that's had a history of this, to give it back to them?
Well, I think of a friend of mine's child. She's now 14. At the time, she was 5 when they started. She was growing too fast, and by the age of 6, she had started her menses. So she was going through a lot.
That's
of
a large
treatments.
part of our patient population.
And I know, and the mother was one of those that was kind of out of control. So what they had to do was, actually, the mom had to stay out of the room. Because the dad was calmer. And that's one of the things you can do is assess who's the calmest parent. And that's the one you want in the room with them. And you really want to plan around the time that parent can come. And I know with me, my daughter had a lot of ear problems and had multiple surgeries. And so I know the one ENT doc would say, I'm not doing any procedure unless you're the one in the room. Because my husband was just like the mom. You needed them out in the hallway. They were just hysterical. And so one is identify who is the calmest. The other thing is, as she was saying, if there are things that you can do to divert, that's perfect. As they get older, I will tell you, as Anna got older, Anna then, because she was a hard stick, always, you know, and unfortunately we have those children that are hard sticks. But one of the things, and the other thing I want to say is, be sure you have the good, I call them the good stickers in the room. Because if you have a child that needs, that truly is a hard stick, you need the best cream of the crop there.
And preparing the child before they come, getting them hydrated, keeping them warm. Tell the parents those are some things that they can do to help you out, to make sure that you do have a good vein to go for. And using the Emla cream and the Freezy spray and stuff like that, to reassuring the parents beforehand
Right.
so that they won't get so anxious, and keeping their anxiety level down is very helpful.
The third thing that I think is really important is, and as Anna got older, and so when she was 10, they had stuck her 3 times, and they really needed the blood, and they said, we're so sorry, but we're gonna have someone else come in that they're even better than I am. And she said, no, we've done enough for today. And so they were, she said, and she told her mother was with her that time. They brought the mom in, and she said, I have to go with my daughter. I agree with her. And so what they did is they reappointed for another day. So there's times that you're gonna have to say, you're right, we've got to do it another day. So the key is really what we're looking at is what's most important for the child. And I know when it comes to pain, part of it is the child will have some anxiety as well. And I can share with you that the mother had cancer, and to give you a little background, and I'll be sharing this when I do my presentation, but there were, in the family, the mother was diagnosed with cancer of the thyroid. 3 months later, her grandfather was diagnosed with cancer. 3 months after that, her second grandfather was diagnosed with cancer. Within a year, both grandfathers had died. And so mom is still undergoing treatment so she had anxiety, and so she started crying. Well, I have a tool that they use, and it's very simple, but I sent it to them for them to use. And so she started using it, and one of the things that I encourage children to do is to write down those that are old enough. The little bitty ones, they can't do it, but as they're older, I have them go ahead and on pieces of paper, just little strips of paper, because they like writing on strips of paper. You can do little Post-it notes or whatever, what they're feeling. And even if they can't spell, it's okay. Or draw a picture if they're illiterate. They still will draw something and that helps relieve the anxiety. But the other part of that is, there's normally a social service person or a counselor or a child care specialist that is involved. Or at school, there's a counselor or a teacher, wherever the child is and where they feel safe. Because sometimes children are afraid to tell someone what's going on because that makes them, someone else, like in this family, their mommy was sick, so I can't put another burden on mommy's shoulders. Now this is a child at the time that was 5 years old. So she started doing that, and she was in kindergarten. Well, she started having anxiety attacks at school. And so they then got her in with the counselor, and so she brought the tool to school with her, and she had all of her little notes that she had written and the pictures so that counselor could look at it. And then as time went along, she still would have episodes because her grandfathers have died now. She would have anxiety attacks in the classroom. Well, she would pull out the tool that I had created, and they would let her set it on the desk. And as soon as the tool was on the desk with all of her little messages in it, she immediately would calm down. So what you want to do is look at what it is that calms that child down.
So
in
that
this
takes
instance,
us-
it was my tool, but there are other tools that will oftentimes calm a child down. It may be, I know some settings they use aromatherapy.
So Deb, that takes us into another arena that we want to bring up.
okay.
So what role does behavioral psychology, child life, the tools of cognitive behavioral therapy, and pain coping strategies, how does that play into our treatment of children with acute pain as well as chronic pain?
And with that perspective, I would like to offer a different perspective on this idea of how we present, does it hurt? We have found, more from the psychological point of view, if you have a child that already has high levels of anxiety, and what it is that brings them comfort is the knowing, then we can say, and we have found that it's helpful to say that this may hurt. It hurts for some kids, and it may not. And I feel like sometimes that's giving the child the benefit of the doubt that they're able to distinguish between the two, and that we're not setting them up for one or the other. My daughter's one of those types of patients. For her to know what's happening, she'll be the first one to say, that wasn't as bad as I thought it was going to be. And she's very honest that way and can look at it honestly that way. But there are a lot of important times that not just saying, you know, I'm not sure what this is going to bring, that there can be more comfort if you say, well, it could bring this, it could bring that. So be, you know, it's kind of like be prepared for the worst and hope for the best. And whatever it brings, you're strong enough to handle it. It's okay to cry. It's going to, you know, you're going to be resilient. You're building courage. And just continue with the positive messages. That's building that psychological piece for them.
Exactly, I would agree with that.
Yeah, I mean, I think we have psychologists who just work with our pain patients, and you know, for them to be able to really help identify those coping strategies. What are the tools, whether it's something physical or something they can go to mentally, that can help them get through these various situations, is really, really important. And I think as we're talking here, the other thing I'm thinking is, if you know and have time to be able to talk to a parent privately before the procedure or poke or whatever, you can do a lot of that pre-work of helping those parents be good support people, and helping them just recognize that their anxiety, that their angst, that the unknown of what is this, you know, we're getting blood drawn for some potentially devastating news related to a long-term condition. So, you know, they've got a lot going on, but if you can really just give them some concrete things, then they can be more helpful in supporting their kids. One of my coworkers has a little guy that was born with glycogen storage disease, and from infancy she was like, there's something wrong, and she couldn't get anybody to pay attention. And finally she got some video footage of what was going on and showed the doctors, and then they worked him up. Well, he was very sick. He had finally got admitted after having to get to the point of having seizures. But from the very beginning, and it's luckily that Lisa works in pain management with me, but she set Mateo up from the very get-go, that this is what it's going to be, this is how we're going to do it, this is not a choice, da-da-da. And so as a now 6-year-old, he just kind of goes in and says, yeah, this sucks. Do it. You know, get it over with. But Lisa's been very consistent and clear, but she also has the advantage of being a pain management person. You know, not all of our parents have that luxury, and I think that gets also the cognitive behavioral piece. I know our psychologists and our child life specialists are much better at determining what a child's disposition is than I am, because they probably spend more time with them. You know, and again, the knowing, some kids, when you're gonna do a procedure, they wanna watch. And we might tell them, oh, look, what, you know, how many times have you had your blood drawn and the phlebotomist says, don't look? It's like, why? I want to see what's going on, you know. And there's kids that are that way. Some don't want to watch. And so those are the kids that you actively distract while the process is happening.
Caveat to talking with parents without the patient. Excellent thing if you can do it without the patient knowing or being present for it. But to separate your patient from the parent and speak with the parent privately oftentimes builds, you know, destroys that trust that's there. And I've watched many wonderful counselors and psychologists be able to talk with a parent in a very successful way in front of the patient, in a way that empowers that patient to know and get everybody on the same page. The ultimate care of the emotional and psychological piece of any patient is definitely lies with the security of the parent and understanding and knowing what's going on. If you keep them calm, you know, and sometimes that's challenging if you have a single parent, because you don't have another option in the room. And so taking the time to really work with both nervous mom or nervous dad and patient at the same time and connect them together to be each other's support gives them a lot of empowerment to make it through this and recognize that they'll have resiliency as a team, as opposed to feeling like one has to be more secure than the other one. Yeah.
How did you repair the bond with your daughter after that scenario?
Great question, yes.
Mom and daughter versus the techniques that you use versus provider and patient.
So we had to, that fourth shot, the particular night we had the 4-hour standoff ended with us restraining her for the injection, which I would never do again. And we had to stop, take a step back. We talked with our nurse practitioner. We said, you know, is it okay if maybe we skip an injection here, let a few days go by, take some time to reset? And resetting looked like sitting down together and saying, okay, it's time to reset. We are sorry for you having this distrust, and this is never what we intended. We would like to talk through more of the eagle's eye view of why this treatment is important and why you complying with it is the difference between Grandma, who's an RN, actually came in. She's the head of the graduate nursing program at our university, and she said, honey, this is, your mom has always raised you to think positively about everything, but the cold hard reality is you taking this medicine is going to be the difference between you burying your mom or your mom burying you. And there's a big difference there. We want to see you be healthy and happy and have a long life. And there really isn't an option to you not doing this. So instead of trying to figure out whether or not you should do it, let's figure out how you can do it successfully. And that started the conversation of what's going to matter, how can we get you on board with this? What, you know, and giving her that eagle eyes view was extremely successful, 10 years old. That doesn't always work with the younger ones, but you can talk it at their level. This is important because maybe to a 3-year-old, it's what's the thing that you can't do yet that you know you want to do. In our particular rare disease, you know, my daughter went from part-time in a wheelchair to the volleyball court in 6 months with this treatment. But the first few months were rough, you know, so that's what we do is get them through those first few months until they can reconcile that pain on their own and recognize the treatment's worth it. But what it always comes down to restore anything with a child is connecting with them. That's always it. It's connecting with them and talking with them and empowering them and figuring out how do we put ourselves on the same team again. Honey, I'm your cheerleader. I'm here. I don't know why God put this in your hands in tears. That's what I said. I have no idea why he thinks you can climb this mountain at 10 years old, but I have no doubt you can. And you're gonna learn so many things on this journey. And that's what life's all about. And you're just learning it a little bit younger that way.
Yeah, and I think that empowering and engaging the patient in the injection it has been helpful for me. The one sentence I use is, you know, the part that you're going to help me with is, you know, most of the time that's laying still. You know, you help me with this part, laying still, and talking through them and telling them each step as you go through it. I don't have anything in my hand right now except for an alcohol wipe and gauze. You know, it comforts them to know you don't have that injection, that needle in your hand right now. So I think engaging them in the process of going through it.
When they're old enough, that's excellent.
Yes,
And that's what we
that's
talk to our
important for
parents
me.
about.
You know, again, engaging them in chatter, you know, and how's your dog doing, and stuff like that when you're setting up, distracting them. We have a distraction toolkit. I keep goodies in my pocket, you know, look in my pocket while I'm getting stuff ready, and they search through there, and depending upon the age, of course. You know, and as well, you know, in getting back to how much information do we give our kids on how much pain it is, again, honesty I think is the best policy. I don't particularly go for the I don't know part because I do like, you know, as Zach even mentioned, you don't like hearing the I don't knows. So, you know, for me to say that to a patient doesn't work for me, but I do engage them in, well, I've not had this shot before myself, so I don't know, but other kids tell me that, and I give them a range, you know, that it feels like a bad mosquito bite, or, you know, have you ever had that penicillin shot in your arm? Well, we're giving it in a bigger muscle so it won't feel as bad, you know, as that. To try and give them a perspective so they can, you know, when you have to restrain a child, some of them we do, some of our Downs patients who don't know, it's not telling them we're going to get someone to hold you down, but we're going to have other people to come in and help us, you know, so that everybody can help. Calling them helpers and not, you know, we're going to have to hold you down if you don't behave, those kinds of things. You know,
So
being
careful of
unthreatening.
your terminology
The terminology, I
and
think,
making it
helps.
developmentally appropriate.
asking for their
Yeah.
help, getting other helpers in, and those kinds of things, and just being honest.
Encouraging especially depending on the age, if at all possible, encourage your patient to recognize what the benefits are of what they're doing, or if that's appropriate. If not, have them talk about something that they're proud of, that lifts them up, that makes them feel good about themselves. If they're involved in a sport, tell me what your position, if you need them to talk about something, get them to talk about something though that makes them feel good. That's the positive association.
I agree with that, and I also have an experience of my own with a child. When we started the injections, it was monthly deep sub-Q injection of cimetidine. It's very painful, and it's a large volume. And she was 2 when we started. And so she had done some other type of injections before, and mom came in and was pretty confident that she would do well. She did okay the first couple of times, and then I noticed that her anxiety started building, and we got to a point at one point where I had to say, let's stop and regroup and figure out what we're gonna do, because she was hiding under the exam table and I didn't do it.
So was there a reward system built into that for her?
So, what we did was, our hospital, lucky enough, had just implemented a new canine therapy program. And I talked to mom separately on the phone. I said, next time I'm gonna regroup and I'm gonna call you and we're gonna figure out what does she like, what will work for her. And mom said she had several dogs at home and she'd like to lay in bed with them. And so, we had one of our therapy dogs come in, and it was like night and day, one visit, y'all. The dog got up in the bed, laid with her, and she brushed the dog as we gave the injection, and that's what we did, every single time.
It's not that complicated.
No.
It really isn't. You gotta find the right
Kids
thing.
know that you're
You know,
like-
for my daughter, it was a box of dresses.
Yeah.
Who knew? Well, I'll buy you a $20 dress if that gets you through this injection. Yeah, but it's finding out what it is. That's why for our program, all of our pain kits that we send out to our patients are customized. So we get a profile of the patient and we shop for that particular individual. So that is the highest level reward that they can get to keep them compliant.
And I think, just a quick comment, our child life therapists all carry iPads around, and they probably have 400 plus kinds of distractions on there for every age group.
There's so many apps.
And they can
available.
be passive distraction, or they can be active, where the kids are actually engaging in a game or something on the iPad, or it can be the thing that I prefer, which is just, the circle of colors, and you just kind of go, and but you have to find what works for that child. And sometimes the one that worked the time before doesn't work this time. So being able to have that flexibility to adapt in the moment, I think, is really important.
Sally, you married?
That was actually one of my questions. So we use technology with all of our patients because that's how we relate best to them. And it doesn't matter how old they are, which unfortunately is sad.
Has anybody seen the distraction towers? Do you know what they are? They are insane. They're insanely expensive, but they are insane as how well they work. They're essentially about they're taller than I am, so they're probably close to 6 foot tall tower on wheels. The center part has a water column in it that when you turn it on, then the bubbles start going, and there's a light changing system so that water changes color. There are fiber optic cables that are attached to it, and you turn those on and they change color. And for a lot of our cognitively impaired kids, those cables are magic because they can touch them and see the changes. It has a color wheel thing that'll play, lights on the ceiling, and they're about, last time I looked, about $25,000 a piece. So, they're not peanuts.
Not in our budget.
Yeah, so, I think we have 3 of them in our institution and use them. But if you've got, your foundations, anybody that's willing to throw some funding toward this kind of stuff, those are, again, other tools that are out there. But our cognitively impaired.
Distraction tower?
It's called the Distraction Tower.
Okay, well, it's not on Google.
Uh-oh, Zach, it's your fault. Find it. Go for it, Zach, find it.
They're probably custom made.
Hold on.
So so one of the things.
Wait,
I'm
Mary,
sorry.
okay.
I said, we have one, we call it Rover.
Oh,
You have a particular name for it.
Yeah, and I don't know if that's what it was purchased under, but it's always been known as Rover.
you could get a lava lamp if you really wanted to try.
And if we
40
can't
bucks
find
at
one,
Spencer's.
I will, send me an email and I'll find out the brand of the ones we have.
There are more extensive bios for our panelists and contact information on the app, so just so you all know. One thing I found very interesting when I asked the panelists to help me formulate these questions was the concept of PTSD and how that really does play into this process of pain management. And so we've been discussing how these early interventions can be helpful in kind of creating an environment around painful procedures. Do you all want to comment on PTSD particularly? Is there any literature that talks about it, or?
I'm not real familiar with the literature, but just my years of experience would be that it's absolutely real, and that if these kids have horrible experiences, they come in, they may come from another health system or whatever, or even just the first time they're coming in. If that first experience is really horrible, you're gonna struggle with every interaction thereafter until you can get those kids some coping skills, let them develop a sense of control and kind of develop a plan. We have what we call our, it's a comfort plan, but it's based on University of Michigan's POPE plan. And so it's a very individualized thing. The child and family sit down and fill out all the different things. Where do they want the procedures done? What do they want done? How do they want to do it? What are their distraction techniques? And that lives with that child in the health system. And so anybody can pull up what's their comfort plan. And that really helps because again, that predictability and knowing that I've had some input into this really helps the kids.
You go next.
Yes, and there are lots of studies. I wish should have brought my list of sources with me, but I left it in the
You
room.
could probably, if you're interested, just email me.
What I can do is I can give them and they can put it on the internet for people. Most assuredly, there is PTSD. Anytime a child has emotional trauma, pain, certainly emotional trauma, there is an element of PTSD. And it's important that indeed we work at helping them through this. And one of the things that I find interesting in the literature, they're also saying that it's just because we think we've gotten them through the PTSD that it won't rear its ugly head again, but it will throughout their lifetime. And so that it's important that they do learn the coping skills, and it's important that it is controlled because with the PTSD, then you can end up having other issues. They've already got major issues going on with them, whatever it may be, but then we get to add hypertension, any type of heart disease, we get to add diabetes to that. They have a 10 to 15% greater chance of having it than a normal person. And then we also get to worry about the depression and other psychosomatic disorders that are going on. The other thing is we get to worry about is how they cope, because we're wanting them to cope normally, but then they can end up becoming very distrustful of people, where the children are cutting themselves, all kinds of ways that we're really wanting to avoid. So it's important that indeed we do address PTSD when we are working with children that have emotional trauma. And there's tons of literature on that.
Right.
Do you feel is the best way, if you're in a smaller place that does not have child life or someone that can evaluate within your facility, a referral to counseling, or?
Yes,
Yes, most assuredly. Yes.
And I think
absolutely.
my sense, I don't know how many of you routinely screen for ACEs in your patients, but in my sense, a child with a chronic illness should get an ACE score. That it doesn't, and they should automatically get points on that score for having a chronic illness.
For those of us that don't know what an ACE score is, could you elaborate?
Adverse childhood events. And I don't know if I'm going to be able to pull them all off the top of my head, but it's any kind of psychological, physical, sexual trauma, poverty,
Disaster.
And there's,
I know there's.
I think there's,
I'm pulling a breath.
yeah, now I'm just blanking, 'cause
Great,
it-
yes.
but it's essentially, it's a very, if you just go ahead and Google, ACEs, what you'll come up with is adverse childhood events, and it describes the work that's been done to validate that tool and its common screening in general pediatrics.
That might be a good screening tool to use in your practice, and just do a little QA project
Yeah.
to see if you can support the need for a behavioral psychologist or a child life person.
So in my private practice, I work with a lot of adults that have early childhood trauma and came from the generations before we had this much sensitivity to the psychological side of medical treatments. And it doesn't take much to have that early childhood trauma in place. I see clients that, maybe were actually physically abused, but I also see clients who had some sort of an adverse treatment when they were young, and it has caused a very real reaction, a very high anxiety, which leads to, what Elaine already said, the other multitude of problems that happen. And then we have, a population of adults that really have trouble with coping mechanisms, or have their coping mechanisms, but don't heal, okay? So the way we see it in our perspective is that there's the ability to cope, and that's wonderful. That's where you need to get somebody, is the ability to cope. But then there's a step beyond that, and that's the ability to heal. That's the ability to have a life that's fulfilling, that you're capable of joy and happiness and all the range of emotions. You're capable of healthy relationships. And that's the thing that I see the adults with early childhood trauma affected by most. They are not capable of having healthy relationships. They're typically divorced, they're estranged from their children, they aren't able to hold down jobs easily.
Substance use disorder.
Yep, substance abuse. Then it just kind of snowballs. So I see PTSD and early childhood trauma as a snowball, starting at a very, very high mountain, and it just drops. And you end up with such a huge boulder, they don't know how to get out from underneath it. So you have the ability right now with the children that you work with to keep that from happening to them. So they have to go through a lot of these, painful treatments, but being able to meet them where they're at psychologically, emotionally, take care of that piece for them, give them the tools they need, gives them the ability to open up the rest of their lives to be healthy and healed about it all.
Great. Any other questions? So
I
I
was
was,
gonna say one thing.
okay.
Just a lot of my patients that are a little bit older, like our precocious puberty kiddos, tend to, or really like to know, how long will this take? Like, I can handle it, but how long will it be?
And that's part of, I'm sure you guys can speak to that, that's part of that control piece.
Yes.
They want to trust you.
And that's a piece, I think, that you can give them that information clearly.
And I think that helps.
Yeah.
Like, for them, they're like, okay, I'm gonna count, by the time I get done for sure counting to 10, this will be over.
Yeah.
It's hard
Although
to
be
back
really
up if you don't
careful,
know, but
because
with
some
injection,
people,
it's-
but some people count faster than others.
Yeah. That's how I get done counting.
Right, and that's the thing, and then if you happen to unfortunately be one of those where it's like, oh, the first stick didn't work,
Yeah, that's what I'm doing.
then but there's definitely, I think you can say this will be a quick thing, or this will, you can give them that perspective for sure.
Be as clear and as ambiguous as you can.
Having control is a huge, as we're already talking, that's huge. And control starts with the thought. So the knowing piece is important. How you express that is even more important, and that's more tailored to the individual, to the individual situation, to what condition you're dealing with, etc. What that looks like, especially if it's an I don't know answer, but still giving them something that they can wrap their heads around and feel confident with, and they're still in control of something. Whether it's how fast you push that syringe down, to which Band-Aid they get, which sticker they get, if you're going to do that injection before dinner or after dinner, that sort of a thing. Giving them any control over it that's ambiguous to the person doing it is giving them a whole lot of that grounding that they need.
Perfect.
The other thing I'd say is be creative. Let you be creative in how you help these kids. I remember I had a kid who I needed to do a lab draw. She had horrible veins, and so every time we drew blood, it was a nightmare. And every day when I went back to my office, I walked by the dental clinic, and I'm like, huh, I bet they got nitrous oxide here. Huh, I wonder if I can convince them to let me use a little. And so I did. I mean, I just went in, I talked to the dentist in charge. I said, look, I've got a kid I've got to get some blood on. Can I bring her up here? Will you help me give her some nitrous? And that, just making that extra effort, let that kid be successful at blood draws afterwards. You know, I mean, she was so clamped down from her anxiety that we could never get blood draw. The nitrous was, you know, she chilled out, but it also is vasodilatory, so then her veins popped up. And that was all we needed, was for her, was that one success to know that she could do that. You know, and I don't know how many of you have nitrous oxide available in your institutions. We have a nurse delivered program, so, you know, we can get nitrous to any of our kids if we need to.
Speaking of getting creative, one of the things that parents tend to do is they always want to try to make their kids' appointments outside of school, right? So they miss the least amount of school. When you have kids that are chronic and have some sort of disease that really takes a toll on them, that's one of the most creative things you can do. So that's what I did with my daughter for a long time is, would you like me to make that appointment during school? That was, hey, she's gonna be really compliant if I'm getting her out of school for it. And that school piece, when she was younger, came very secondary to what we were dealing with that was changing her whole life. And so that was just something that was a little bit of a spin. Now she's 12 in junior high, and oh my gosh, make everything you can after school. I don't want to have to make up work. But I gave her that control, and that was a big piece that was a reward in and of itself and didn't cost too much. So that's something easy to recommend to parents also is, what's the big deal if they miss a class or they miss half a day? Treasure that time with them, make that important. I would always, you know, we'd go out for ice cream or do something, but it was also an opportunity to connect with her, to talk about it, to do that processing so it wasn't something she buried and later had to deal with or cope with. She got to process it out, talk about it, and then go back to school. And it was that worked out really well for us as far as getting creative.
So we're running out of time. I just want to give you all one chance to ask any more questions. I will recap, and if you'd like to speak with any of our panelists afterwards, you have burning questions, please feel free, if that's okay with you guys.
Yes.
All right, great. So we pretty much unanimously decided that early procedure intervention is best. So looking at what the child's temperament is, identifying what the parent's temperament is, and what are some of the things that we can do pre-procedure to kind of get them to understand what's going to happen and relax a bit. Be honest, build trust. Those are two really critical things. Empower the child and give them some choices, and that will help us in the long run. Use distraction and engage them. Positive experience with painful procedures early on will help them cope with painful procedures later. Consider using child life or behavioral psychology services if available. You can always refer to outpatient if they need those services in your area. You can just Google behavioral psychologist, cognitive behavioral therapy, anything like that. And assess for PTSD, signs of anxiety and depression, and consider doing ACE scoring for your patients. All right. Well, I would like to thank you all very much. I think you're very
Thank you for all the great questions.
Yeah, great questions. And thank you guys for helping me learn more.